Salam to one and all. It gives me immense pleasure and honor to introduce the next speaker for the day, Professor Dr. Fanindra Yalavarthy. To speak a little bit about our distinguished speaker, Professor Fanindra Yelavarthy obtained a MSc degree in engineering from the Indian Institute of Science, Bangalore in the year 2004. He received a PhD working as a US Department of Defense Breast Cancer Predoctoral Fellow in Biomedical Computation from Dartmouth College, Hanover, USA in the year 2007. He then worked as a postdoctoral research associate in the Department of Radiation Oncology, School of Medicine, Washington University in St. Louis, USA from 2007 to 2008. Currently, he is working as an associate professor in the Department of Computational and Data Sciences, Indian Institute of Science, Bangalore. He served as the chair of the department for the period 2016 to 2018, as well as institute coordinator of Prime Minister's Research Fellowship PMRF scheme for the period 2018 to 2020. He was the chair of Office of International Relations OIR for the period of 2018 to 2021. He currently serves as the chair of Office of Development and Alumni Affairs ODAA. Coming to his achievements, he is a recipient of Apple Laureate Award in the year 2009. He also received the Department of Atomic Energy Young Scientist Research Award in the year 2010 and a co-author of the work chosen for the International Society for Magnetic Resonance in Medicine ISMRM Merit Award in the year 2012. He is a recipient of Indian National Academy of Engineering INAE Young Engineer Award and Innovative Young Biotechnologist Award, Government of India for the year 2013. He also received the National Academy of Sciences India NASI Young Scientist Platinum Jubilee Award in the year 2014. He then spent 1 year, that is 2015, of sabbatical at Health and Medical Equipment HME Division of Samsung Research and Development Institute, Bangalore, working on post-processing algorithms for clinical application of magnetic resonance imaging. He received S. Ramachandran National Bioscience Award for the year 2020 from the Department of Biotechnology, Government of India. His research interests include computational methods in medical imaging, deep learning in medical imaging, medical image processing, reconstruction and analysis, physiological signal processing, diffuse optical imaging and photoacoustic imaging. He is a senior member of IEEE, OSA and SPIE and serves as an associate editor of IEEE Transactions on Medical Imaging. He has 5 patents to his name and numerous publications in various peer-reviewed journals and conference proceedings. Without further ado, please join me in welcoming Professor Dr. Light on the topic, Deep Learning in Medical Imaging, the Road Ahead. Sairam.
That's a long introduction. Thank you very much. Sairam to all of you. It's my pleasure to speak at this event. I would like to thank Dr. Gauri Shankar for inviting me here. Can somebody confirm that they can see my slides?
Yes,
very good, thank you. So now that it is confirmed, so I would like to jump ahead and then start off on my topic. Before I go further, I have some conflicts of interest or disclaimer. I receive research funding from various private agencies, including GE Healthcare, Shell Technology, Biocon, and then as well as Beckett and Dickinson. But for the work which I am presenting here, none of this funding was utilized. Even though I am presenting here, a lot of this work was done by my students, and I would like to acknowledge all of them who have contributed to a lot of my work here. And as I said, we also receive funding from non-government and non-governmental sources. In the governmental sources, we receive funding from Department of Biotechnology and SCR. Without further ado, I would like to break my talk into these topics. I will just give a two-slide introduction to medical imaging. Talk a little bit about AI in radiology, and then jump to our own lab's work, which is related to COVID-19, because now COVID-19 is a hot topic. And then I will go into something like what are the new topics which people can explore. Those of you who are interested in picking up a research topic on this. So let me just jump into the medical imaging general introduction. Disease. So the way it happens is that on the left side bottom you see that we are acquiring these images, and then on the right side bottom you see these clinicians who are really making the diagnosis or visualizing the lesion or disease. In between is where we all work on, and it's a broad field called as medical physics. And so how do you convert these data which gets acquired from the scanner to something which can be applied? And we call it a computer analysis, and that is where I work primarily to convert the raw data into something which can be applied readily. So once you have these images, so once you have visualized these images, there is something called as radiological interpretation happens. So in some sense, what is the abnormal tissue which you are able to see, and things like that. So now, based on that, you rule out or rule in a diagnosis. So if it is a cancer, you are going to say whether somebody has a cancer or somebody doesn't have a cancer. Needless to mention, it's very important to note that imaging is only 1 degree of information which gets in for the diagnosis. There is other information which typically the clinicians use as a cohesive one. It is called as integrated diagnosis. So now, again, so there are multiple imaging modalities that exist in the clinic because each one of them have some utility. So I think the talk before this is mostly about optical imaging, where you will be able to look at the information at the molecular level. And then, if you want to go slightly above than the molecular level, then you are talking about metabolism level. So then the nuclear medicine comes to play. MR is kind of mostly about morphology and physiology. It can give few metabolism as well. And now I have indicated what does it mean in terms of how many cells you can image. So whether it is a, we call it as microscopic tissue versus macroscopic tissue. In some sense, you can say that if you are able to do something at the molecular level, probably you are going to detect cancer at stage 1 itself. As you move up in the ladder, you are going to have a physiological change or a morphological change, which is mainly structural change by the time you move into stage 3 or stage 4 of the cancer. So if at all you have any chance of detecting something, so then you have only with optical and nuclear medicine. That's the only thing which I wanted to mention. So of course, whatever I'm going to talk about is going to concentrate a little bit around CT, and then then you can see what other topics which you can pick up when I talk about road ahead. So in a simple one, in the clinic, we call this as a workflow. Radiology is one of the main unit which uses the imaging as their main workhorse. And we call that as a workflow. How does the images or imaging data move? So if you think about it, you have the acquisition, which I just talked about, and then we do some computing and processing and analysis, and we generate these images. And these images have some tasks to do. So this could be like, detection of a tumor or abnormal tissue. This could be characterization of this. This could be monitoring over the time. And based on this image-based task, you generate one report, which is purely from the images. And this report goes into this diagnostics, which is integrated, where I mentioned about not only imaging data, but you look at some pathology data. Probably you are also going to look at some genomic data. You are going to look at clinical correlations. You are going to look at the patient history, and then going to make a diagnosis on top of it. So now purely imaging is one part of it, but then you have all these image-based tasks which requires from the images to characterize certain things. And that could be like, segmentation of the images, that could be diagnosis, that could be staging. If it is monitoring, you want to know somebody who is going through a cancer treatment, you want to know whether the tumor size is decreasing, increasing over the time, such that you can assess whether they are responding to the treatment or not. Now, the reason I mentioned that as a workflow is that, this workflow is really time consuming. And a typical generation of the report after the scan takes anywhere between roughly about 24 hours to something like, you can say a week. 1 day to 7 days is a very common thing for somebody to generate a report and be part of the integrated diagnostics. If it is emergency, then people do it very quickly, but those mostly are not read by radiologists, mostly read by emergency radiologists. So now let me jump into this and then a little bit introduce artificial intelligence here. Then I'll come back to the where does AI fit into the radiology in a while. I don't think today, you can do any task without AI being there. So it's pervasive in daily life, starting from the ads which you see in your browser to something like Google Home, Google Assistant, your cell phone. Everything is there, and so this is called as recommender systems. Currently, most of the recommender systems which pops up ads on your browser and other things are powered by AI. And there are many tasks AI can do, but including I will just spend a little time on the expert systems. That is what essentially we'll be concentrating on. At least in the medical imaging, that expert system has a lot more usage. So again, I don't want to give a history of it, but just I wanted to say that it is not really a new field. AI has been around for some time. So around 1950 is when we have started the AI. That is when the coining of the term AI has come in. John McCarthy, who is the father of AI, said that artificial intelligence is the science and engineering of making intelligent machines. And when he meant intelligent machines, he's talking about especially intelligent computer programs. So remember that AI essentially means that there are intelligent machines which have intelligent computer programs. Now, I think today you can really say that AI systems are the ones which learns from the experience. When we say experience, these are mainly data-driven. And currently there are tasks which are already there, like recognizing the images, like your Facebook. When you upload something in the Facebook, you can immediately see that it recognizes faces. Or your camera, when it is focusing on somebody, it's going to show the face. And ideally, it uses the learning to reason. So that means that it's going to learn from the data and then reason it out. And ideally, it should also solve complex problems. It can understand the language and nuances. That's what Google Home does for you, or your cell phone in the voice recognition. But more importantly, the AI system, one of the important tasks it should do is what we call it as creating perspectives. So that what is meant by perspective? That means that we say that see the unseen. From unseen data, can it give you some inferences? So that's what AI system is expected to do in a new situation. Based on what has already been seen, can it do something? Now, if at all, I want to define, because the topic of my talk is deep learning. So I just want to clearly define where does deep learning fit in. If you think AI as a superset, this was there since 1950s. Mostly these were devices which were mimicking the cognitive functions. These were not very complex cognitive functions in the 1950s, but now it has become. The machine learning is mostly about the algorithms that improved on the cognitive function utility-wise. And since 1980s, we call them as rule-based kind of stuff. Most of the machine learning tasks are mainly rule-based ones. Then, then came the deep learning. So this is because of the artificial neural networks, which are deep enough. So if you want to know what is the difference between machine learning and deep learning, if you have more layers in the convolutional neural network, you can call that as a deep learning model. And if you have only a single layer or maybe only 2 layers, then you can call that as a machine learning algorithm. But both of them are learning algorithms, remember that. And so this is what has happened since 2010 when general purpose GPU one teraflop computing on your desktop. So because of the GPU computing, so the deep learning has become a fast growing field. So again, I don't want to get into this, but I just wanted to say that, thousands of years ago, science was empirical. For example, think about like, Newton asked this question, right? Why did the apple only fall down? Why it didn't go up? So that's an empirical observation which he had. And from there, there came a theoretical branch and things like that. So which was mainly a mathematical models to it. In the last few decades, we have been talking about computation as a fourth leg for the science, theory, experiment, and mathematical model. Now you are talking about computation of it, where we want to build models using computer. So now in the recent world, we are talking about data. So machine learning from big data is what we say is the new paradigm for the science. And anybody who is not doing this, is going to miss out on something. So that means that now we are talking about learning from that data, which is there. Remember, the data collection was there all the time, but only the new thing is the learning, which has to happen based on the data. Now, in a very simple sense, if you ask me what is the fastest growing field in AI right now, it's the deep learning. And as I mentioned, it should learn from the data. The data could be structured or it could be unstructured. The structured is like, you can imagine like medical data being structured because you have electronic health record, you have EMRs, you have imaging data, which is a particular sequence of a particular organ and things like that. And you also have to make the deep learning algorithms as scalable. We say that can it learn as a feature hierarchies, and so that means that we are talking about large networks which are deep, and it has to learn on its own, right? So whereas in the machine learning we call it as feature engineering, we engineer certain things and then give the learning. So that means that some amount of priors we give quite a bit, so that the machine learning is only doing a very particular task. Whereas in the deep learning, we are talking about working with a really large data and learning all the features on its own. So that's called as feature learning. So that has to also be scalable. It's not only limited to a small data set or anything. It has to also be scalable. But more importantly, what we say is that it has to see the unseen. So that means that it should be able to draw the inference on the unseen data. What is being missed out by a clinician, can it pick it up, or can it advise the clinician to look what is important is. Now, I know because the deep learning being really the fastest growing, there are many papers that come out. Interesting enough, Nature, even traditional journals like Radiology also have artificial intelligence is built into their publications. Now, just to give as a single field, medical imaging used to be the largest publishing cohort. I mean, as an area, medical imaging used to publish probably the largest number of papers per year. So this is by topic. Now, once machine learning and deep learning started taking over, I mentioned 2010 is when GPU computing power has come into the picture. So now, roughly in around 2013 onwards, now today, machine learning, deep learning, AI, actually as a single topic, artificial intelligence publishes the largest number of papers. So it has surpassed the medical imaging for sure. So there is a lot of work that goes on there. So now, anyway, let me jump back into, now that I've introduced a little bit of AI. So I'll jump back and then introduce AI in radiology. I mentioned this. I said that once you have acquisition of the images, you have these image-based tasks. And based on these image-based tasks, you are going to generate a report, and then you are going to have a diagnosis on it. So now what happens is that when we do this kind of tasks, which is either detection, characterization, and monitoring, one of the biggest problem is that nowadays most of the medical images are 3D or 4D. So that means that either it is a 3-dimensional or a 4-dimensional. So that means that these image-based tasks, probably you have to do it for multiple slices. And probably you have to do 3D plus time as well, going over time as well. So now you can imagine a typical brain scan, if you want to look at it, typical brain scan will have roughly number of slices. If it is a CT scan, it'll have at least 50 slices. So if you have to detect a brain tumor, now you have to go through all the 50 images and carefully do all these tasks. So again, if it is 3D plus time, now you imagine that you have to do it over the time also. So that's going to be time consuming for sure. And then you have all these complex protocols because the technology is evolving, and it is not only CT. In CT itself, you can do, we call it as non-contrast CT, contrast CT, you can do CT perfusion, you can do CT angiography. So there are many, many protocols which you can do the way you generate the data itself. Model imaging modalities like MR, PET. You also have PET CT, so which will give you multimodal information. Now you also have to do this task both on these images. So it gets into quite a bit of complexity associated with it. One is that the protocol itself is evolving over time, and then you also have all these new imaging devices which are multimodal in nature, which are giving you those images, and now you have to do all these tasks. So obviously then you require, you need to spend quite a bit of time. So that is when, the AI has some utility in this. Just to give why do we require AI in the radiology is that, globally, there is a shortage of radiologists. So roughly, for example, just to give a number, for about 1 million people in the US, you have about 2,000 radiologists roughly. And then, if you are thinking about like in India, for about 10 million people, we have about 45 radiologists. So that's quite a low number if you think about it. So that means that there is a shortage of radiologists. If you expect the radiologist to go through these time-consuming and complex protocols, the radiologist is not going to go through so much of that. There is going to be a delay. The turnaround time is going to be quite heavy. So it's going to be a slow process unless you introduce some automatic detection and AI tools. And more importantly, there is a better diagnostic accuracy. Remember, AI is a machine and it doesn't get tired. Whereas as a human, you get tired. You might be a better person in the morning compared to the evening. By the time you touch the evening, you might be getting tired. So, when you are tired and when you are doing these complex tasks, you may not be really reporting accurately quite well. And the accuracy of current reporting, which is purely human, is only 70%. So you make 30% errors. So that is really a big number if you think about it. So that means that what it is going to do is that it is going to allow you to have a lower rate of So now again, of course, this is the one set of problems. The other set of problems is the growing and aging populations. India, to a certain extent, this is not true. India is a lot more younger nation, but most of the Western countries are having older population, and countries like Japan, their average age is increasing over the time, and so that means that they are going to have, some comorbidities which are going to come with the old age, or are having some morbidities associated with it. In any case, this aging population requires more health care. So that is something which we have to account into. And healthcare costs are also going up. Currently, the cumulative annual growth of healthcare cost is close to about 25%. So every year, if you are thinking from last year, if something has costed 100 rupees, the cumulative annual growth for that is now today it is going to cost around 125 rupees. So within 1 year, that's a 25% increase is what is currently healthcare cost is. There are these operational inefficiencies, and then there is a staff shortage. I just mentioned about radiologists. And this is not a problem in India, but in the Western world, CMR codes, which is mainly the Medicare and Medicaid, so they have to approve the reimbursement. So if at all you want to get the money, insurance should approve that. So that asks for value-based reimbursement. Does all these procedures at all needed or not? Now, in terms of workflows, I talked about radiology workflow. There is a complexity of integrated care. So there is also time-consuming tasks. Then I said that there is a diversity in the patient protocols. There are these errors, which are about 30% currently in terms of reports. More importantly, can you follow up, right? So the patient gets dropped down in the middle, can there be alert? such that you can do a follow-up. So these are all the current challenges which are there. So it ideally in the AI should fit in terms of, primarily we talk about 4 different things which it should be able to do very easily. One is operational optimization. So when we say operational optimizations, for example, I just talked about CT of the brain having 50 slices. So now if I want to read the 50 slices, can it point out the most important slice I should start reading as a radiologist? So that means that I want to know what should I start off with, such that it becomes very quick. So that's such that I can get to the bottom of it very, very fast. And it can also help me in terms of decision support as a radiologist. The AI as a doctor can give you second opinion. That's what we call it as empowering the patients. So if that model exists, can you upload all your images and get the diagnosis done by AI? And population health management. Obviously, the COVID-19 at least has put population health as being one of the important factors. And ideally, AI should be able to do all these tasks very easily. And in terms of imaging, what we wanted to do is that there are these medical imaging devices which are generating all the data. And we actually store it in something called as PACS, which is Picture Archiving and Communication System, or in VNAs, which is Vendor Neutral Archives. So now you can imagine that we can build one kind of a model. This is the Intel model, which it is telling you what platform it can build, such that these trained deep learning models can provide the inferences as soon as the images are required, such that it can quickly tell you whether somebody has a cancer or somebody doesn't have such a disease very quickly. But of course, this has to be validated by a radiologist. But right now, that is the whole task. And I think I already mentioned this. What traditional machine learning does is that you have some kind of a feature engineering. So you have an expert like me who have studied the medical physics, who can understand the images a little bit better, image formation. And then we say that probably this feature is the one which distinguishes abnormal tissue to normal tissue. Maybe it could be texture, it could be intensity, it could be shape. And then we pick up that feature. And then we select that feature which is distinguishing the abnormal to normal. And then we want to classify it, whether it is benign versus malignant and something like that based on the feature. Of course, now to do the feature engineering, you require a domain expert who can read those images and then tell you what feature they are really looking at, such that you can engineer that feature and then give it to a classification. What deep learning tells you is that, if you want to distinguish into malignant versus benign, it will learn on its own, right? So you have these multiple layers which you are going through, and it will do the feature learning for you. These are all convolution layers. In a very simple sense, the traditional machine learning, what it does is that, it has a feature extraction step, and then it has a classifier, and then it is going to do the prediction. Whereas the deep learning one doesn't have any of these. It will learn on its own as long as you have enough data, and it will do the prediction for you. Of course, the feature extraction may not universally work. That is also same thing for the deep learning as well. It depends on how good is your data is. And currently, most of the learning we are doing is very task dependent. And at least the traditional machine learning requires understanding of imaging physics and have a little bit of clinical knowledge, such that you can do a feature extraction very well. And I'm just going to give one example here. So this is a drug-induced interstitial lung disease. DILD is something which is very hard to diagnose, because this requires somebody to sit and look at all the chest CT images and then do a classification based on the features. And I just wanted to point out here the SVM, which is the standard machine learning method, is giving about 90% accuracy. And whereas the feature learning one, which is CNN based, is giving you something like 96% accuracy without doing any feature engineering. So roughly this increases the accuracy by 6% without doing much, and everything being available as a large data. So this is what excited, and this was way back in 2015. So this is what excited a lot of people to work on a lot of AI tools. And again, you can also say that, why to do only for images? You have a lot of other data, like genomic data, you have proteomic data, you have metabolic data, you have, all the radiomics, which you can mix up. And then together, can you not do a prediction? So that, everything is, even integrated diagnostics, you are bringing in deep learning into that, and then doing all the predictions. That is also equally possible. Of course, there are many companies which work in this space, at least in the medical imaging space, which are utilizing AI as their workhorse, and then this is a really large number. Now we can ask the question, right? So now, if you have to develop such a DL model, how many images do you need? And what if we don't have enough data? And what if we don't have enough annotations? Like benign versus malignant is one annotation which I just spoke. And this, to a certain extent, I don't have answers for this. These are all research questions. Even now, I don't think anybody has a definitive answer how many images are required for a particular DL model, or how much data is enough, or what will you do if you don't have some annotations as well. So in terms of model, right, so now what we are doing is that we are taking a data and then we are trying to develop a CNN or a model for it and then want to get the result. So in terms of model, you want to ask the question, do we really need a deep learning model itself? Can I not do a simple machine learning model? So that's a valid question. And is there any off-shelf models? I'm going to answer this question. That is what we work on the model selection. How can we incorporate the context or prior into the models, right? So now in the machine learning, we are doing a feature extraction and doing classification. So at least if not feature extraction, can I not use some prior such that we can improve the deep learning model? Is there trainer-friendly models, right? So can I do something as a trainer-friendly? As a trainer, can I do something? So I'm going to partly answer these questions through the talk, but these are all big questions which are actually currently burning almost all the deep learning field, not only in medical imaging, but everywhere. Now, in terms of result interpretation, can we visually interpret the result? Remember, the DL, what it is doing is that it is doing a feature learning. Now, we don't have the features to represent per se, right? So can we look at those results and then say something that this is what is the feature it is learning? Maybe the texture is what it is learning. Can we say that? Right now, it is a black box, which we don't know. Can we obtain human-friendly interpretation, like what I said? So when as an expert, I might be looking at a texture. And if the deep learning model is also, the feature it has learned is also texture, so then it's called as human-friendly interpretation. So, can we correlate? Right now, explainable AI is also another big field. So right now, there are not that many models that exist or that many methods that exist which can explain the DL result, deep learning result. So let me just answer a few questions which we can look at it. So now, the main, you have to understand why we need to use a deep learning models. So one is that, we want it to be better than the humans. So the opinion on between person to person, site to site. So that is, you can remove that if you have a machine model or a deep learning model. And obviously, the performance increases with deep models. The more depth you have, the performance increase, provided assuming that there is infinite amount of data available. Now, again, in terms of off-the-shelf, those of you who are interested in, if you want to do biomedical image segmentation, I will say please use UNet. It works very well with small annotated images. If you want to do a 3D segmentation, there is something called as VNet, which is the expansion of UNet. And it has some skip connections and residual functions, and VNet is better for this. And Inception V3 is something which will remove the variability. For example, like if you have pathology data set, you have even microscopic data set, which has a lot of variability in terms of illumination, in terms of size and things like that. So you can use Inception V3. These are the rough things which we start off with. If I have to start off with utilizing some or developing a DL model for a particular task, so this is what we use. Depending on the task, we pick up one of the off-shelf models and then utilize it. So now I'm going to jump into our lab work. Before that, I can take one question if somebody has a question, quick question. Are there any questions? Okay. So if there are no questions, then I can move on and then I can take the questions in the end. Okay, so let me jump into this. So we are, I want to present one of our work which we have done recently on the COVID-19 management. using chest CT images. So before I go, I just want to introduce our lab. The group I work in is called as Medical Imaging Group. We are part of the Computational and Data Sciences department in IISc. Primarily, we train PhD and MTech students, and as somebody mentioned, our primary interest is in the computational methods in medical imaging. So what we do is that we primarily work on inverse problems, which is image reconstruction. So that means that the raw data which you collect from the scanners, how do you make sure that gets reconstructed as images, which is interpretable by the clinicians. We also work on image analysis, and we also build expert systems which are assisted to clinicians. So the work which I'm going to present on the COVID-19 is more of an expert system. And of course, the total theme of this, all the computational model is that, you want to make the unseen visible. So now, I'm sure COVID-19 has put all of us down. I think that's why we are also meeting virtually now. So let me just give a little bit glimpse of how does the COVID-19 progress itself in terms of what it does to the chest or lung. So now this is a patient which has been diagnosed with COVID-19. So on January 21st, I wanted to focus on this red box. And this is the CT image which has been taken, and you can see a little bit of this fibrosis type, right? So this structure which is there in between the red box, which looks like a little bit whitish. This is, we call it as anomaly. So this is a COVID-19 anomaly. And in a bit of space. Now, when you do RT-PCR, the candidate has been taken RT-PCR, which is a COVID-19 test. It is just going to tell you, whether it is positive or negative. Now, what has happened is that after January 26th, the patient has gone through the treatment. And about a month later, you can see that, these anomalies have disappeared in the images where the yellow arrows are. And now, after almost 4 weeks or 3 weeks after that, you see that it's completely got cleared out. So this is what happens when somebody gets through a treatment. And if they are responding to a treatment. If they are not responding to a treatment, then, their anomalies are not going to go down. So in essence, you want to characterize, how much of the anomalies are there in the lung. So this is what we call it as scoring of the just CT images. So that means that if there are anomalies which are no anomalies present, we say it's a normal lung. If it is having 24% of the area as anomaly, we call it as mild. And if it is occupying little less than 50%, we say that in its moderate COVID-19. If it is 50 to 74, we say it is severe. And greater than 74, which is 75% or more, we call it as extreme. Now, the red ones, which are the staging of 3 or 4 of the COVID-19, which is severe and extreme, they are the ones which are supposed to be taken into the ICU. So they are the ones which requires intensive care for them. So this is, in some sense, it will allow us to choose who is the patient who should go into the intensive care or not. So now again, I want to say that chest CT anomalies, there is something called as ground glass opacities, pleural effusions and consolidation. These are all part of the chest CT anomalies. So now, I don't know whether you have heard this or not, when COVID-19 was on the rise, or at least was severe around August to October period, now every hospital ICU was, who should be admitted in the ICU was a big question. So there were reports saying that, people unnecessarily got admitted in the ICU, they may not require ICU, or who should get home treatment. These were all the big questions which were presented. So what we wanted to do was, we wanted to develop a model, which is a deep learning model because it's an image-based task. And such that, our main aim was that it should be able to run on any platform. It should not require any specialized hardware for it to run. And it should be natively running on something. So we said that, somebody has a mobile phone, can they run this model on that and then get the severity of the COVID-19? Like this, like 0%, 24%, like this, scoring. And we wanted to ensure that it natively runs on the mobile phone, it natively runs on any platform you give, and it doesn't require a GPU or any specialized hardware. So We started developing this, and any of you who are interested in architecture, we use something called as bottlenecks, which will allow you to have a very lightweight CNN, and we use something called as anamorphic depth block. So that means that in the Z direction, we squeeze it such that you can get a very less number of parameters to train. I will show you that example as well. But essentially, you give a chest CT image, it will do the segmentation for you as COVID-19 anomalies and non-COVID-19 normal lung, and then give you a percentage. And again, those of you who are interested in the little bit more details, we used a weighted cross entropy, and we weighted it by each label. We have essentially 3 labels. One is non-lung region, and normal lung, and COVID-19 anomalies. So there are 3 labels for us. So we have given a weighted cross entropy, which is weighted by each label, how much is there, and in the training set. And again, we use publicly available. So these are all the data sets which we have used. Roughly, this comes from close to about 70 patients' data. And roughly, if you think about it, there are about 5,000 slices which are available. And we have also, I already mentioned UNet, which is off-the-shelf model which you want to use. So now I just wanted to compare where does our model stand compared to other. So if you are looking at UNet, it has 31 million parameters. The size of the model itself is about 120 MB. And if you want to train it, it will take about 51 minutes. And if you want to get inference, it takes about roughly half a second. And whereas what we developed, these are all the rest of the models, I will not get into that, but what we developed was a very lightweight model, which is about 7 times lesser than UNet, which is 4.47 million. And it occupies roughly, 1/8 of what is available with the, 1/6 of what is available with the UNet in terms of memory. And the training time is roughly half an hour, and the inference time is also 1/3 of a second. So that is what we have ended up with when we have trained. And the reason why we wanted to squeeze is that, for example, the UNet, you cannot run it on a mobile phone. And if you want to run it on a mobile phone, this model, it doesn't. It requires a GPU to run because it has so many parameters, and even to train also you require quite a bit of GPU for it. So now in terms of accuracies and results, what I wanted to show was we were not that bad at all in terms of accuracy. So despite of having very less number of parameters and other things, we were getting close to about 98%. And the only other model which was giving very good accuracy was UNet++. And that is similar to UNet, but it has a lot more parameters, and it cannot natively run on mobile phone. Now again, this is just to show what happens. You give a chest CT image, and this is what is supposed to be the anomalies, and this is what our predictions are coming out to be. So the green ones are normal lung, and the red ones are these COVID-19 anomalies. You can see that it does reasonably well in terms of getting that numbers. It has better accuracy for the normal lung compared to the anomalies, because anomalies are multiple of them which are yet to get. Now again, we wanted to just show that it doesn't require specialized hardware. So we even ran it on the Raspberry Pi, which is a simple embedded system. We also have an Android application. Those of you who are interested and want to play with it, which you can install it on a mobile phone, and it will do that. I will just show you one example. And those of you who are also interested in GPU-based embedded system, NVIDIA Jetson is one good example, which has a small GPU like Raspberry Pi. Raspberry Pi doesn't have a GPU built into it, but NVIDIA Jetson has that, and then you can run some embedded systems, models, AI models on it. So now, those of you who are interested in the Android app, you can actually download from here. And this is just showing you a screenshot. Now you input the scan, it will tell you how much is the anomaly region, how much is the normal region, and how much time it has taken to do the inference. You can load it from your own mobile phone. So this is something which we have done. And if you are interested in more details, there is a paper which is available in the, we just got published about 15 days back or so on the fast track for the COVID-19 focused papers on the IEEE transactions on neural networks and learning systems. So you can look at this paper as well. Hopefully I will also share the slides with Gauri Shankar, such that he can share with all of you. You need not worry about not having this information. Now, I'm going to just change gears and then get into the new topics. I'm going to be quick with this such that I can close it right on time at 12 o'clock. So right now, what we are doing is, if you think about it in a very simple sense, we are acquiring the data, which is this green arrow, and then we are doing a reconstruction of the images. And then from these images, we are getting these features, right? So for example, like the work I showed you goes from images to these features, which is telling you like, look, this much anomalies are there in the chest CT. And from these features, we are getting into some actions. So the action could be like, who should be admitted in the ICU. So we say that, if it is, extreme or severe, which have anomalies more than 50%, then they should be admitted in the ICU. That is what is the action we are taking in the COVID-19 case. So now if AI or artificial intelligence is all that powerful, or DLA is all that powerful, deep learning, why to go about convolutedly this way? Why not go from data directly to the actions? Our action is we want to know who is the best candidate for admitting in the ICU, or who has the more severity such that they can be admitted in the ICU. So can I not jump into that action using the data itself? Why to reconstruct the images? Why to extract the features and then get into the actions? Why not go from a question which, hopefully, it will be answered in the next a decade, such that we'll see such kind of models. So that means that, we are talking about something like, bypassing almost 2 other steps and then going directly from data to actions. Other than that, there are other topics like, reading the medical images. Currently, what radiologist is doing is essentially he or she is creating a report from the images which is there. So that is essentially reading of that. So can we convert that image into a text, and then can we mimic that and give a draft report? There are models which are already available which can do that, but it is a little slow. And we are also talking about image reconstruction and image physics. I think that I already spoke about. And those of you who are interested in looking at the roadmap, this was published in 2017 by the White House. What everybody is talking about is this, because big data is a big thing, you want to have the standardization. You want to have the best practices in imaging going across the site to site. So currently, most of the best practices in imaging are locally done. That means that at a particular hospital, at a particular location only it is being done. If there is something that is working out beautifully, and artificial intelligence is good at picking up those, can we really expand that to everywhere? So that means that you are talking about bringing that in this. And more importantly, what is happening is that most of the current referral is based on the experience of the clinician. Can we make it as evidence-based criteria? Can we put it in an objective way by using a DL model into this, such that the patients who get referred to some other hospital or some other procedure, are objectively getting it done? Now there are many unexplored areas. One of the things is that can we learn from the equipment logs? Remember that most of these radiological equipment is a expensive equipment. So these are all like cost you probably a couple of crores to a couple of 10 crores. So now the equipment being down is a loss of money, loss of care as well. So can we learn from that equipment logs, saying that when the machine is going to be down? Or can we learn from the equipment log that the artifact which you are seeing in the image is due to this? And so that means that we are talking about automated quality control. Right now, the way but if there is something which will automatically alert saying that this image doesn't have the quality, can at least we can keep the patient back and then probably rescan if it is permitted as per the radiation norms. But right now what happens is that we bring back the patient because because the patient has moved, and we realized it only after a day or two, and then again have to rescan because they don't have enough quality. Obviously, that is a loss of time. Again, a procedure being again redone is also pushes back the line. So that is also another problem we have. So we are talking about this quality control as well. developing 3D models, real-time feedback on image quality, right? So when I say real-time feedback on image quality, can we say that this image is good enough for an AI model to run? Or the input to the AI model should have this quality, that is what the training data had. So now once a new image comes, can we really look at whether this image is good enough for the AI model to work or not? Or can I say that based on the image quality, this is probably the best AI model for us to look at it? I just mentioned UNet and Inception V3. We said that if there is a large variability, we said the Inception V3 is what you should use. If it is a small annotation data, UNet is what you should use. So now the question is, now once the new image comes, which model to run? So can we choose that? So that is something which is also an unexplored area. There are many challenges for the adoption of AI. I mean, one is that it's still a black box. Nobody knows what is going on. And the problem is that if you give a very low quality data, you have garbage out, which comes out. So that means that, you may not be able to get the correct diagnosis if your quality of the data is low. And universally applicable large data sets, I'm going to show a couple of examples. So the data set might be very localized. So the model might work well there, but it may not work in another site. And fully integrated solutions. So that means that, it is not like a radiologist who can read ultrasound images, who can read, PET images, who can read CT images, who can read MR images. Still, it's a very task-specific model. So that means that probably it can do only one task at a time, like what we did COVID-19. COVID-19 work is just reading chest CT images alone, right? If you give MR images, I don't think it will read that. So the failure of earlier CAD systems is one thing. CAD is computer-aided detection or diagnosis. That also has, really putting back a little bit back step for the AI. Fear of replacing the clinician. So there is a lot of fear that, the AI models and the artificial intelligence is going to replace the clinician, even though that is not true. Compliance-wise, when there is a misdiagnosis, which one will take the ownership? In a very some sense, who has to get sued? Can I say that, because the data doesn't have enough quality, the AI model didn't work? Or can I say that AI model is not good enough for us or made the wrong diagnosis? So this is also another big issue. Now, I just told you, right? So I'm going to go and show you a couple of examples of where AI and DL didn't work. So there was this national lung screening trial for the lung cancer where they were looking at lung nodules. And they were segmenting the lung nodules in this national lung screening trial. The AI model which was developed was giving accuracies around 90%. So the lung nodules were able to detect about 90%. When they brought that model and then applied it on Oxford University Hospital data, the accuracy has gone down to 60%. So that means that, it was giving almost 30–40% errors. So which is quite a bit, right? So now, it didn't work as we wish. And there is something called as also adversarial attack. So that means that what you do is that even a small noise in the data will actually lead to accuracies falling down quite a bit. And these noises are very common in an X-ray type machines, because the reason is that X-ray tube keeps on heating up. And as you use more and more, especially the long scans, you have a quality, beam hardening effect, which will not be the same type of SNR is what you get. So now when you are adding small noises, the accuracies were falling down by 15%. So it was not immune to these adversarial attacks as well. And of course, the biggest failure has been this IBM Watson Health. This is called a Watson for Oncology, or Watson's AI Doctor. So MD Anderson, which is in the US, has spent about $62 million in getting that and installing it in their premises. And then finally, it has not gone well. And then they have just put it outside and said that we will not renew the contract. And they have stopped utilizing it. Now, I'm just coming to close. In my view, at least AI in terms of radiology and clinic, it works the best as assistants or adjuncts. I don't think it will replace the clinician in any manner. And ideally, it will combine the human knowledge with the power of these intelligent analytics, such that you combine the machine and the human, and then you are going to make a big impact, like 1 + 1 being greater than 2. Mathematically, it is not possible, but here you can do that. Precision medicine and population health is going to be the key for the AI, because there are new data sources. It can tackle the complexity. And population health anyway has become more important in the COVID-19 cases. And the prevention and patient education. So in some sense, early warnings of something happening, and engagement on a personalized manner is always helpful. I think COVID-19 also has shown that the prevention is more important in almost all. And you increase the value-based care as well. And that is where I will stop. I have more topic, but anyway, I will stop here and then I'll be happy to take any questions.
Thank you, sir, for your insightful talk. Now I throw the session open for questions.
Dr. Phaneendra, there are a couple of questions in the
Sir,
chat. You can probably answer them.
Yes, I can read out the chat and then I can answer that question. So let me start on the first one. I think Subhakant Sahu asked this question: how much time a deep learning imaging model take to learn its own? Well, the learning depends on how many layers you are putting and how much is your training data is. Depends on your GPU power, computing power as well. The quick answer to it is that if you have a powerful GPU and something like UNet takes about an hour for it to learn something, assuming that you are answers the question. So let me go to the next question.
Yeah. Is it using Raspberry Pi itself? That 1 hour, 1 hour duration for using the Raspberry Pi?
No. So we have not really done the training on the Raspberry. We have done the training on the non-GPU. We deployed it on Raspberry Pi such that it natively runs on it.
Okay.
If you have to run it on say something like NVIDIA Jetson is a better example.
And how many images are required for this learning process?
Okay, that's a good question. So it depends on what you want to learn, but roughly, we will say anything around 500 and above are good.
So you are getting the images of the COVID from the COVID hospital, is it?
Yes, I mean, it's not really our hospital, but it is somebody in Norway who gave me those data with annotations.
Oh, thank you.
Okay. And so there is one more question I can take. And Inception V3 for segmentation of data like histopathology, whole slide images. Okay, so this is a good question. I mean, I don't have a definitive answer for it, but one thing I wanted to mention is the whole slide images in the histopathology are very big. They run into GBs. I mean, one image itself could be as big as 1 gigabyte. So now if you have such a big image, it is not possible for you to run any model, right? So it won't take, it has to happen as a patch based. So your training still has to happen as a patch based. And so you want to look at it. So something like what we use is a GPU called as RTX 8000, which has 48 GB as the memory. And we have 2 cards in one machine. So totally it gives you something like 96 GB. So, we can a little bit of models on that. But having said that, it doesn't solve the problem of 2 GB as an input. Still, you have to do patch based only. And because UNet may not really work. UNet is encoded decode architecture, which doesn't have a residual connections or skip connection. So it is a hierarchical model which cannot really learn so much. So I will still use Inception for it. Okay. And give an idea in depth and number of feature maps, what we are looking at in models in comparison to for the proposed model. Okay. So now I wanted to say that depth-wise it is the same. So we have used the same number of layers. What AnamNet has compared to UNet. Number of feature maps wise, the dimensionality of the feature map is quite low here because we were doing a bottleneck. We were squeezing in the Z direction. So in a very simple sense, it is at least, in terms of feature map, every layer is decreasing it by 1/3. So in this case, I think we used about 30 layers. So you can say 1 over 3 over 30 is the feature map which we have reduced in this. So that's a good question as well. Even though we have reduced the feature maps, still we are doing a classification task. That means a pixel level classification. Each pixel in the chest CT has to say whether it belongs to normal lung, or whether it belongs outside the lung, or it belongs to COVID-19. So these are the three classes which we were putting it as a classification. Okay, and I have one more question about, is there a possibility to train model for medical image classification using RNN model, since we are dealing with time series data, like patient is recovering, like what you showed in the sequence of images using COVID-19. Well, RNNs you can use. I mean, even though I personally don't work on the time series data, we were only work with the static data. There are people who work with RNNs using a time series. One of the quick example is the CT perfusion. So there are people who use CT perfusion data using RNN. Okay, so then Vijay Sai has asked this question. Human interface can predict the noise as noise, and machine will not be able to do that. Well, the definition of the noise is what is not a signal. So in a very simple sense, the human has a lot more things in the context. So we call it as contextual based interpretation. So the human knows what case the human is looking at and what is expected. And the human is also going to have a lot more additional information that comes into this. So that means that, like, the human might have the patient history. The human might have checked with the nurse, how did things go? And then only they are really looking at the images. Whereas in the deep learning model, all it is looking at is only the images, right? So it doesn't have the context, right? So under what circumstances the patient has gone in, right? For example, like in the COVID-19 case, you can ask the question, right? The human might know whether the patient has walked in for the scan or not, right? So that means that if the patient has walked in, so that means that they have enough lung function, because you can only walk in if you have enough oxygen in your body. So in some sense that gives you the context. So human is better at that, whereas machine is not better at that. So then there is one more question. So is analyzing chest CT images for COVID detection? You have discussed various models. A model based on LED is having lesser learning time, lesser detection time. Can you tell how? Okay, so the LED net is one of the lightweight networks which you can train. But having said that, the accuracy is not that good. So let me go back to that slide. And then show you that, right? See, LED net has very less number of parameters. Actually, the most lightweight network is something called as efficient net, ENet. It has only about 300K, about 350K parameters. But LED net has almost 910K parameters, right? And size-wise also, ENet is much smaller than the LED net. It is having 16 minutes as the training time and 298 milliseconds, right? As the number of parameters go down, your training time obviously goes down. Now, LED net, if you look at the accuracies in terms of sensitivity also, it is, for the abnormality, the sensitivity is very low. It is not very sensitive. And even in terms of dye score also, it is giving far below than what our network was giving. So in some sense, that's why our network has turned out to be better. So that's why we said our net is better. It says that chest CT scan reports CORAD4 means. Okay, so the CORAD4 is a medical code which you can use. And of course, when we did this work, COVID-19 didn't have CORAD scores. only now, post January, the CORAD scores for the chest CT for the COVID-19 have come into the picture. So earlier we didn't have, so otherwise we would have classified into that CORAD scores as well. So at that time it was only moderate, severe, extreme, normal. So those were the classes which we have classified into. Okay, how do you go about annotating data in the medical field, especially since it requires doctor's time? Well, this is a big question, right? So that's why we have models which are annotation efficient. So there is no single answer for this. We still require the doctor time. The doctor has to sit and then do the annotation for us. So if you look at our own paper, the annotations were done by a radiologist in Norway. It is not a radiologist who is in India. So because during the COVID-19 peak time, everybody had, radiologists were very busy. Right? Okay, so now Abhishek has another question. Like IBM made their AI model Watson. Is any company in India which is working on any such model which will help diagnosis in real assisting the diagnosis process? Well, I don't think there is anything like that in India that is happening, which I can think about. But there are these initiatives which government wants to do. For example, if you are interested in, you can look at something called as National Digital Health Mission. So NDHM is part of the National Health Authority, which is part of the Ayushman Bharat. NDHM has this big vision of developing these AI models and having kind of a marketplace for anybody to go and download the model and then utilize it for their own diagnosis as a third party. I think I have answered any questions, and any other questions, please feel free to ask.
Thank you, sir. If we have more questions, we can take it offline. We'll be sharing the speaker's email ID with you all. Thank you, sir, for the wonderful talk on this most wonderful area, deep learning in medical imaging. It was indeed an inspiring and a thought-provoking talk, and I hope it has inspired us all. We hope to hear more from you, sir, in the coming future. Thank you. Sai Ram.
Thank you. Thank you very much for having me.